and that
Namaskar.
thoracic
Namaskar.
surgery. Namaste, sir.
Namaskar.
I'll start the clinic with your permission.
Yes, yes.
Yeah. So a very good afternoon and a very warm welcome to NITRD Central TB Division and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it's my privilege to welcome Dr. V.M. Katot sir, DDG sir, and all the state TB officers, directors of STDC, team from NIRT, NTI, faculty of medical colleges, district TB officers, medical officers, and others. I will start with introducing the faculty from NITRD. I am Dr. Neeta Singla, Nodal Officer, DRTB Center at NITRD. And on my right is Dr. Rupak Singla. He's head of the department TB and respiratory diseases. He's also the mentor for this clinic. On my left is Dr. Saroj Meena. She's a chest specialist at NITRD. Now I would like to request our director, Dr. R.K. Diwan sir, to give his introductory remarks.
Namaskar, everybody. Good afternoon. Thank you so much for joining, and it is a great privilege to be seeing such luminaries as Dr. Katot having consented to join, who has been a guiding scientist par excellence, who has been guiding most of us to, in fact, start clinical research, go into it, and reach higher heights. Thank you so much, sir, for joining this prestigious meeting. This is our recent initiative from NITRD, which we are holding a national level difficult to treat TB clinic, which is attended by 800 to 1,000 doctors across the country. It's held once a month. And the type of cases which are discussed here are highly instructive, and they show that despite the best possible recommendations, algorithms, and flow charts being created by the best experts in the country, we still get cases which are perplexing, which drug to be used, in which case at a given moment, even when all the tests are at your disposal. And the discussions which are across disciplines of chest medicine, microbiology, and sometimes thoracic surgery also. The kind of discussion which is generated is quite lively, interesting, and instructive. And we will be very happy and pleased to hear your guidance on this issue. Thank you so much, and best wishes for the meeting which goes on further. Thank you, Neeta, for having asked me to start by this. Thank you. Go ahead.
Thank you, sir. Thank you. Before I welcome Dr. Katot, sir, I would just like to inform him about our clinic. Sir, we started this clinic for knowledge dissemination about 5 years back, and we have been using this platform for dissemination of knowledge for last 5 years. And in August 2020, we started the Difficult to Treat TB Clinic in collaboration with Central TB Division and National Task Force, with the objective of providing solution to management of difficult cases of TB. This concept was recognized as the need of the hour and was incorporated into the PMDT guidelines of the country. It has now extended to all the states in the country. Currently, more than 26 states are doing these clinics regularly. And this, through these clinics, the whole country is working together to provide solution to difficult cases of TB, and also helping in capacity building of states and medical colleges in managing difficult to TB cases. So, sir, with this, I extend a very warm welcome to our guest of honor, Dr. V.M. Katot, sir. Sir is a renowned microbiologist. He was Director General ICMR and Secretary Health Research. Currently, sir is president of AIMS Madurai and JIPMER Pondicherry. He is also chairman of Lepra Society. Sir has several national and international publications of repute to his credit. It is our proud privilege, sir, to have you here in our clinic. Sir, I request you to say a few words.
Thank you, Dr. Neeta. Thank you, Dr. Diwan. Well, I must thank Dr. Rupak for this invitation, and it's so nice of him. I see Professor Rajendra Prasad, I see Dr. Jai Kishanji, I think Dr. Joshi is also somewhere among these, or nearly 200 people who have joined. But I must, today address Dr. Rupak, Dr. Neeta, and Dr. Meena, who are sitting on the center stage today to, I think, steer today's discussions from their side. When I read this idea, and Dr. Rupak briefed me, and Dr. Neeta will talk just now actually, I think it's a very marvelous idea, which maybe came a bit late, but it is there actually. It's a great idea. Because what has happened in tuberculosis, over the years, people like Rajendra Prasad also will say that we have cured lakhs and lakhs of people, but we have messed up also. And that messing up is due to, their individual freedom to do whatever we feel like actually. That has been the excellence, clinical excellence in India, but that is the clinic, that is a prescription for the damage also. And that I saw in my entire career, when I was monitoring about 38 districts in Uttar Pradesh for drug resistance, we found, that there were a cluster of the very peculiar type of profile of resistance. And it emanated from two clinicians who were, one of them had double MD, MD medicine, MD chest also. And they would have cured lakhs of people. I'm not saying hundreds and thousands of people, but then they had a method in their flawed method in their management, which led to a very peculiar resistance also. So I think that that's nobody's fault actually. They do in all good faith. Actually, everybody does in good faith actually, and you succeed. But then down the line, you create a mess somewhere. You create a mess. Maybe that life is lost. Maybe the profile is changed totally. So I think this clinic is a wonderful initiative, I think, with a great idea, Dr. Rupak, and all the people who have backed you, right, in your institution, in the CTD, in the National Task Force, and all these 26 states which you're talking about. I think this collecting together will not only save lives, but this will lead to, a regimented evolution of the management also. Because these difficult cases are something, not only a problem for those cases who really suffer and die, their families, but this is for the entire society, because it's the mess we created down the line, which several generations may not be able to correct it. So I'm very delighted this one afternoon to join all of you. The DRTB is also there, so I think it's a program we connected with you. And all the people, I think more than 200 people who are there, many of will be learners, but most of them will be contributors to the process, because it's a big scene, large number of people contributing. And the last comment is, what has happened, the tuberculosis management in the last at least 1 decade has very rapidly changed with the introduction of so many drugs. That is another mess, I tell you. That is a great opportunity to do better, but that is another challenge of what is the right thing to do, because that experience is not mature actually to the different settings, different genotypes, phenotypes of the people. So I think this clinic will contribute to the evolution of the better and better management of tuberculosis, of not only difficult, but some ideas to make the things so robust regimens for future. Not only individualized, that's the immediate goal of you, but a better regimens to treat the tuberculosis in general in this country. With these words, I thank you once again and wish you all good luck. Thank you very much.
Thank you, sir. Thank you so much. Sir, we started this idea of difficult to treat clinic about 1.5 years back, and we've been running this clinic. We did for about a year. We identified about 20 national experts. The CTD identified these experts, and the cases were sent to CTD. All the difficult cases were coming to CTD, and CTD was marking these cases to these experts who were giving a solution to these cases within 48 hours. So we were building up national capacity as well as state capacity. And then we started with, as I said, 26 states are doing, and the cases, which were almost 20 cases per month, have now gone down to just 1 or 2 cases per month. So there's a lot of capacity building happening through these sessions that we are doing. So, sir, with this, I would like to start today's proceedings. From last month onwards, we have started inviting the states by rotation to share their difficult cases from their states, so that we all get an opportunity to learn from their experiences. So in these sessions, we have an expert from the state, and then we have a national expert. Today's clinic is from Mumbai, Maharashtra, and presenter is Dr. Shreyas Godbole from KDMC Rukmani Bai Hospital. And the expert for the case from the state is Dr. Alpa Dalal. She is Chairman Noble DRTB Center at GTB Hospital, Mumbai. And national expert for the case will be Dr. Rupak Singla. So over to Dr. Shreyas for case presentation.
Hello, good morning, one and all. First of all, a big thank you for Dr. Alpa Dalal, madam,
and all the dignitaries on the dais to give me a platform to present one of the difficult cases that we have encountered in the last year. So the case history is that the patient is a 32-year-old male, a daily wage laborer with no addictions. He has had a past pulmonary tuberculosis in 2013, for which private AKT, 4-drug AKT was taken for 6 months, but unfortunately no details are available at this moment. The patient developed productive cough with low-grade evening rise fever and fatigue and a 3 kg weight loss. This was in January of 2021. So this was the chest X-ray of the patient on 11th of January 2021, which shows right upper lobe consolidation. So based on these chest X-ray findings, the patient was started on H300, R450, E800 and pyrazinamide 1500 by a general practitioner. At this point, his weight was 58 kgs. The patient continued anti-TB treatment with him over the next 2 months, but with no improvement in clinical status, the patient opted for government AKT. The gene expert was sent on 28th of March 2021, which showed MTB detected medium and rifampicin resistance was detected. So this patient was referred to DRTB Center Kalyan at Rukmini Hospital for initiation of an appropriate DRTB regimen on 5th of April 2021 with all the treatment evaluations. At that point, the patient was initiated on the standard all oral longer regimen with bedaquiline, levoflox 1000 mg, linezolid 600 mg, clofazimine 100 mg, and cycloserine 750 mg. Subsequently, the patient followed up on 5th of May, that is 1 month of treatment. At that point, the patient was clinically better. His appetite had improved. His weight had increased from 58 to 60 kgs. But we were able to trace his LPA report at that point, which showed resistance to not only RPOB, but also INHA, CATG, gyrase A mut2, and to RRS. With a resistance to low-level fluoroquinolones being identified and probable sensitivity to high-dose moxifloxacin, the regimen was modified and levoflox 1000 was stopped, and instead moxiflox 800 was introduced. Subsequently, patient was lost to follow-up at the DRTB center. He was clinically better. He was continuing medicines as per the TBHB and was sending all the sputum examinations as was advised. He could be reassessed at the DRTB center on 28th of August 2021. At that point, 4.5 months of treatment was completed. Clinically, he continued to do better with no cough, no fever, no new symptoms. Appetite was normal, weight was stable. And on X-ray, there was also improvement, at least partial improvement on the right upper lobe lesions. There were no new lesions at this point of time. But we were able to trace his baseline sputum culture reports, which was done at the time of diagnosis. There was a resistance to moxi at 1.0 dose and also to pyrazinamide. Linezolid at that time was sensitive. The 3rd month follow-up culture was sent in July and was awaited at that point. So there were regimen modifications that were done as per the LPA and the LCDST report at that we had. There was resistance to, on the LPA, there was resistance to ethionamide, high-dose isoniazide, to low-level fluoroquinolones and to injectables. And as per the LCDST report, there was now also resistance to high-level moxifloxacin. So the only 2 drugs, the only drugs in the replacement sequence that were available to us were delaminid, ethambutol, and PAS. The patient was counseled regarding bedaquiline extension, and since delaminid was not available at that point of time, a request was sent for its procurement, and from the available drugs, ethambutol and PAS was added. We tried to get a 14-drug extended DST via the program, but somehow we were not able to do that. The patient was not affording, so he could not get it done from a private source. The next follow-up was after 1 month, approximately on 15th of September 2021. At that time, 5.5 months of treatment was completed. Clinically, he continued to do better, but he was not able to tolerate PAS. There was severe vomiting. His LFTs were normal. Symptomatic treatment with ranitidine 300 twice a day, ondansetron 4 mg TDS, metoclopramide 10 mg TDS was started. He was also tried to switch from the sachet to the tablet, since at some point of time PAS was not available. There was a shortage of PAS even in the private sector. 3 months of symptomatic treatment for the control of vomiting was 3 weeks of treatment was given for symptomatic control of vomiting, but still patient could not tolerate even a single tablet or a sachet of PAS. So unfortunately, we had to discontinue PAS on 7th of October 2021. But at that time, the positive side was we were able to initiate delaminate since it was available to us. We were also able to trace the 3rd month culture report of the patient, which was negative at this point. The linezolid dose was reduced to 300 milligram, and now the regimen was bedaquiline, delaminate, linezolid 300 milligram, clofazimine 100 milligram, cycloserine 750 milligram, and ethambutol 1200 milligram. On 10th of December 2021, that is when 8 months of treatment were completed, clinically better, and even the 4th month culture negative. At this point, patient started developing progressive peripheral neuropathy. The offending agent was linezolid and was stopped. The patient, as per neurologist's opinion, was started on pregabalin 75 milligram, nortriptyline 20 milligram, vitamin B12, and other supplemental medicines. Patient was not affording for EMG NCV. With the conventional dose of these medicines, there was no clinical response to his peripheral neuropathy. So an opinion of a palliative and pain care specialist was taken on 1st of January 2022. And as per his opinion, gabapentin 400 milligram, nortriptyline 10 milligram, that is gabapin NT tablet, was started at a dose of 2 tablets thrice a day. That is a total of 6 tablets a day. Patient was counseled regarding the probable side effects, that is a slight dryness of mouth and drowsiness. Patient did report some dryness of mouth, which was tolerable, but there was no significant drowsiness. Over the next 1 month, there was significant improvement in the neuropathy symptoms. The doses of these medicines were tapered down and were stopped over the subsequent 2 months. On 27th of March 2022, this is the regimen that the patient is taking: bedaquiline, clofazimine 100 milligram, cycloserine 750 milligram, ethambutol 1200 milligram, and delaminate 100 milligram twice a day. So 6 months of delaminate have now completed, and delaminate was stopped. So with the past exposure to ethambutol in 2013 and a suboptimal dose of ethambutol given by some private practitioners prior to referring to the program, and no known drug sensitivity profile to ethambutol, it was decided that we will further extend the bedaquiline and will not rely on ethambutol as an active medicine in the management. Monthly ECGs were taken in view of an extended BDQ. There was no QT prolongation. Current status as of April 2022, 12 months of treatment has been taken. Current regimen is bedaquiline, clofazimine, cycloserine, and ethambutol. There is good radiological improvement. He is clinically better. His weight has increased to 63 kg. All follow-up cultures are at present negative. So at this point, there are some questions that we have regarding the further plan of action for his patient. The first question is, do we reintroduce linezolid now that the neuropathy pain has completely resolved and we are left with 3 proven effective drugs with a questionable ethambutol? What are the odds of recurrence of neuropathy or a new ADR, that is pancytopenia, with linezolid? And which among these will be the right regimen for this patient moving forward? Whether we introduce linezolid and stop bedaquiline, or we continue bedaquiline and do not reintroduce linezolid, or we introduce both and as and when side effects develop, we will keep changing the regimen. With this, I'll hand over to Dr. Alpa Madam.
Thank you, Dr. Shreyas. And before I invite Dr. Alpa for her management, are there any questions for Dr. Shreyas on the history of the patient? So there is one question on bedaquiline, how long to give. So I think it's a good part of management. Any question? If anybody needs any clarity on the case, any queries, then we can take it up now, and then we go to Alpha. So, Dr. Alpha, since there are no questions, we'll move on to our expert, how she proposes to manage this case.
First of all, thank you, Dr. Singla sir and Dr. Neeta for inviting me on this forum today. And I with all the dignitaries on the dais feel privileged to share my thoughts on this dais. So Dr. Shreyas very well presented, very clearly presented case, and as we discussed earlier, so I would like to now the management and issues that that have come up already in this case, and what future issues can come up, and what we see in the field conditions. As Dr. Katoch has initially shared, and it's very true that though we have guidelines in place, in real life condition, we face a lot of issues. So how to apply these guidelines in real life situation is a real challenge. And this platform is really helping to bring about all these issues and discuss and find solution. So let me summarize the case. He's a 32-year-old male. This is a pre-FQ XDR because the other drug from group A are not resistant according to the new definition. Fortunately, the disease is limited. It is just limited to right upper lobe. There are no comorbidities, though the challenges are that he has had multiple adverse drug reaction to various drugs. There is past exposure to first-line AKT once in 2013, and this particular episode before he was diagnosed to have MDR-TB, he was treated with first-line AKT. And it's unfortunate, as Dr. Katoch just shared, that even in today's time in city of Mumbai also, this is happening, that general practitioners are initiating patients on treatment in the private sector without doing the sputum smear or gene expert. And this is really unfortunate. And she was started on substandard dosages. So he received low for weight dosages before he got diagnosed with MDR-TB. And that was for good 2 months he received these dosages. And presently, the fortunate part is that he is doing well clinically, radiologically, and even microbiologically. He is improving with all past cultures negative. Dr. Shreyas?
Yeah, Dr. Alpha, there are 2-3 questions which have just come up regarding the history of this patient. Can we take them now?
Yes, sure.
Yeah, Dr. Suru?
So, ma'am, the first one is from Dr. Ravinder Sinde. So they're asking why all oral regimen was started, because it was only the lesions were present localized to upper lobe only. So why all oral regimen was started?
So the reason why all oral longer was started is that the patient had prior exposure to category 1 drugs. There is a very high level of background fluoroquinolone resistance in Mumbai and Peri-Mumbai region. And since the patient is from a not so affording background, it would have been difficult to maintain regular follow-ups for this patient. So keeping all these things in mind, an all oral longer regimen was opted for, as was later justified as per the DST profile.
So,
You, sir.
Just can I say something? You see, in these cases, it is very important when to give shorter regimen, when not to give shorter regimen. Especially in a place like Mumbai, where there is a high baseline resistance to fluoroquinolone. So before we start the shorter regimen, shorter MDR-TB regimen, we must ensure that there is no fluoroquinolone resistance. And in this case, by the time patient was diagnosed as resistance TB, we did not have the report of second-line LPA. So we could not rule out the presence of FQ resistance, and in Mumbai, I am told more than 50% of the MDR they are having FQ resistance. So in such a scenario, if you give shorter the bedaquiline containing shorter regimen, then you are giving an insufficient regimen to the patient, and these patients are likely to have resistance to bedaquiline, to clofazimine, and to fluoroquinolone. It is always better in such a scenario that we start with one or longer regimen, quickly follow the results of the second-line LPA, and then take a decision whether it needs to be revised or not. So this thing Dr. Shreyas has also mentioned. So that's how it is. Thank you.
Yes, I fully agree with Dr. Singla sir that this is unfortunately many places this is happening. It is clearly mentioned in the guideline that second line LPA we should rule out fluoroquinolone resistant, but still pending the report of second line LPA, patient get initiated on shorter regimen, and in field conditions sometimes patient do not come back for follow up within a month or 2 months time, and they continue to take shorter regimen. And then they come back with worsening of their disease. And by the time if there is extended resistance, we have not left with anything else. And now once we have all oral shorter regimen with bedaquiline availability, it would be even worse if we initiate the patient and if patient worsens, we would have hardly any drugs to be added for changing the regimen of shorter to all oral. So I think that's a very important point to be noted. So
Alpa, may I come for a second?
Yes, sir.
Actually, I must say that was a very welcome step that you, the Shreya went for the longer regimen. As Rupak said very rightly, in Mumbai, the background is there's a lot of fluoroquinolone resistance. So that was a very ideal step. Otherwise, you have made mess out of this case. And this is what happened. Alpa, you said also, and I also see in various presentations, people opt for shorter regimen without having clear concept of what is the drug resistance pattern because of the delay in getting the report. So I think it was a very welcome step. Thank you.
Dr. Alpa, then there's one question. Should we be deciding treatment geographically then? Like Mumbai, we know the FQ resistance is very high. It may not be as high in other parts of the country. Should the states be coming out with their FQ resistance and taking decisions accordingly?
So I think even at national level, at least it is not that low also, the fluoroquinolone resistance. It may not be as high as we see in Mumbai. So ideal case scenario would be that you have to ideally get the second line LPA done before you have the report. But in certain situations where the bacillary load is less, and you may not have direct upfront LPA being done on the sputum sample, or sometimes it is extra pulmonary sample, then you may not have the culture coming positive and having the LPA report. And in that scenario, sometimes at least in Mumbai, we take a stand that we start upfront at least with high dose moxifloxacin. And later on, once we have LPA report available, and if it shows fluoroquinolone is sensitive, then we can step down from moxi high dose to levofloxacin. That is what we do at Mumbai. I would like to have Dr. Singla's comments also on this.
Yes, thank you, Dr. Alpa. I think it's a very specific question, and the specific answer will be whenever in a case of RIF resistance TB, you have to start a regimen. First, rule out at least fluoroquinolone resistance. Also, if possible, rule out that there should not be INS plus CADG resistance. So, in case you do not have the report in hand of FQ resistance, please do not start the shorter regimen. You go for the longer regimen and then quickly follow the report of second line LPA. In case it says sensitive, you can switch over to the shorter regimen unless there are other contraindications. In case it says resistance, you're already in the right regimen for the patient. So that should be the protocol everywhere in the country, irrespective of the state. Thank you.
So next slide. Okay, so what are the challenges in this case? As I see that this patient had multiple adverse drug reactions and multiple replacement had to be done. And another challenge that we have in this case is complete DST is not available. Here at this point, we were actually very badly missing having a complete DST where we had to replace certain drugs and not knowing and having prior exposure.
Gautam, hum nahi aa payenge. Please, I'm sorry, main do.
Then another issue that happened that once we knew that fluoroquinolone was resistant, according to the replacement sequence, ideal drug to have replaced fluoroquinolone would have been delaminate. But delaminate at that point of time was not available. Fortunately, we are having delaminate available now. Then another challenge was whether to extend bedaquiline or no. So I'm going to discuss, this is also clearly mentioned in our guideline, what is to be done. And regular follow-ups and monitoring does not happen in the field. And this is a real challenge which all of us face, that at nodal TB center or at DRTB center, we initiate the patient on certain regimen. And like in this case, initially when the patient presented to a DRTB center where Dr. Shreyas started him on the regimen, he did not have second-line LPA report available. And then in the field condition, this patient, when the LPA report comes, may not be guided or may not understand the right time when he's supposed to follow up back to the DRTB center where regimen change is required. And this, I think, is responsibility of all the DTOs and the medical officer, that their health workers who are working under them has to be trained that once the patient has their DST report, they have to be referred back to the DRTB center for making regimen change. And so this is a challenge. Another challenge, develop ADR in the field, they may not be picked up on time, and then patient end up developing very bad irreversible ADRs and comorbidities. Next slide. Okay. So one has to understand that what is the purpose of monitoring and follow-up. So many a times they said that when patient is initiated on a particular regimen, and it so happens in nodal centers or at DRTB center that patient primarily come to us for initiating the regimen, then the next follow-up would happen when there is change from CP to IP to CP. But in between, monitoring and follow-up is extremely important, and this important has to be realized, that what is the purpose of monitoring and follow-up. So the first important thing after starting the patient on regimen is to trace the pending DST reports, and they have to be referred back to the center for adequate regimen change. The second important purpose of monitoring is symptom, whether patient is responding symptomatically, whether patient is responding radiologically, and what are the follow-up cultures. So only on one front, if patient is improving, that's not enough. On all three counts, there has to be improvement in symptoms, clinical improvement, weight gain, settling of tachycardia, there has to be radiological improvement, and there has to be improvement microbiological. Next. The third important purpose, and this is a very important purpose, is to pick up adverse drug reactions. So sometimes patient may not understand, so we have to do a symptomatic screening, ask the patient actively whether they are developing symptoms. This is especially true for neuropathy, because it starts with tingling, numbness, and then later on, if this is missed, and patient end up developing severe pain. Periodic investigation we ask for to pick up any abnormality and development of any ADR, like monitoring liver function tests or amylase, lipase, electrolytes, etc. Then patient themselves present with symptoms, like in this case, he presented with gastrointestinal symptoms or neuropathy symptoms, and that's how you pick up the ADR. And the management of adverse drug reaction, most important is to stop the drug, to change the medication. And another very important aspect of management of adverse drug reaction is that while you are changing the offending drug, you should be very conscious and aware that you are replacing it with the effective drug, and you are not compromising the effectiveness of the treatment. And this is what commonly happens, because many times patients develop ADR, the offending drug is stopped, and not enough thought is given, or probably patient is not referred to seniors or to the higher centers to find the adequate replacement of the drug, and that becomes the major cause for treatment failure after a few weeks or few months. So I think this is a very important point to be addressed. Next. So coming back to our case, patient's ethambutol sensitivity is not known, and he's already used this for 2 months. Okay. Now the question that Dr. Shreyas had asked, that whether starting linezolid is okay in this case. Now we have to wait for the symptom to subside, and fortunately this patient, his symptoms have subsided. So linezolid can be re-challenged, but many times we see almost 50% of the patient, they do not tolerate restarting of linezolid, and they may develop symptoms again. He's a young man, 32-year-old, and if he develops symptoms again, that's going to affect his work, his career, everything, and that may not be acceptable to him. Then continuation of bedaquiline. So continuation of bedaquiline is what I would advise. Restart linezolid at 300 milligram per day and watch for recurrence of the symptoms or any other ADR with linezolid. We'll obviously continue clofazimine and cycloserine because these are two drugs which patient is never exposed to before, though we don't have DST available. And stop ethambutol, because I would say patient has already received ethambutol in the past. He has received during this episode for almost 2 months at a substandard dose, and we do not have the DST available. So I think unnecessarily exposing the patient for the toxicity is not something which personally I would say that ethambutol can be stopped. So according to me, the new regimen would be bedaquiline, linezolid, clofa, and cycloserine. And linezolid, depending on whether patient tolerates it or it develops the symptoms again, you can decide whether to continue or no. Next. So this is all actually mentioned in our guidelines, and just trying to revisit our guidelines, March 2021, the latest guideline that we have. There is clear-cut mention of how the replacement sequence should be and what are the principles of replacement, and that's very important. Each and every sentence I would think is important. So the replacement, when you replace the drug, preferably it should be fully oral. Then what is the sequence of replacement? The first in the replacement sequence is delaminate, second is amikacin, third is PZA, fourth is ethionamide, then PAS, ethambutol, and carbapenem should be the last. Now we all know about the sequence of the drugs, but third point is extremely important, that when you are replacing the drug, it should be according to their efficacy, no demonstrable resistance. So ideally you should have DST pattern. They should not be preferably used prior for more than 1 month. Patient should tolerate, so side effect profile is very important. And the background resistance according to the National Drug Resistance Surveillance Report. So all these factors have to be taken into consideration. Now coming back to our case, the same slide here. Okay, fine. The next slide we discuss and then we come back to our next slide. Bedaquiline and delaminate can be used together when adequate regimen cannot be formed, which is what was done in this case. But initially, when we wanted delaminate to replace because we found FQ resistant, delaminate was not available. Then delaminate and amikacin will not be started in final 12 months. So if you miss the initial opportunity, there is no, the guidelines mention that delaminate and amikacin should not be started in the final 12 months. But here is an issue that suppose initially delaminate was not available and now it becomes available later on, what should be done? Whether we can, in such special situation when earlier the availability was not done, whether we can take a different approach. The extension of bedaquiline and delaminate beyond 6 months can be considered in patients where only 2 of the 5 drugs are available due to high background resistance, non-availability or non-reliability of DST, and adverse drug reactions. And in some special situation, PPAL can be considered. So coming back to our case, our patient had fluoroquinolone resistance. Later on in the liquid culture DST, we found that there was resistance to high dose MOXIE, that is a concentration of 1. And also there is one point which I would like to discuss later and would want input from some of the seniors in the group. So here patient's FQ is resistant. So ideal replacement would have been delaminate, but that time delaminate was not available. And that is the reason where PAS was started and ethambutol was started. Because at that point of time, we did not have, delaminate was not available. And at that point of time, we had LPA report available, which showed that INH is resistant. Yes, you can go back to the previous slide. Yeah. So INH showed that INH resistance was there. So ethionamide was out. Then we had liquid culture DST, which PZA was out. And we started the patient on PAS and ethambutol because delaminate was not available, and that's why from group C, 2 drugs were to be added as a replacement for moxifloxacin or as a replacement for fluoroquinolone. But patient did not tolerate PAS at all. So he had severe gastritis. So we had to stop this. So delaminate was not available. Amikacin we didn't want to because preferably this should be an oral regimen. PZA was resistant. Ethionamide was resistant. PAS patient could not tolerate. And that's the reason he was left with ethambutol, which we do not know, very questionable, usefulness because of previous exposure. And so this was the scenario here. And later on, fortunately, we had delaminate was available, and he developed the adverse reaction to linezolid. So linezolid is out. So now we have option of ethambutol, we don't count at all. So we have bedaquiline, which is on, clofa, cycloserine, and linezolid, we do not know whether it's going to react to linezolid again or no. So we are left with bedaquiline, clofa, and cycloserine. Now in this case, if we stop bedaquiline, probably he's left with only 2 drugs if he does not tolerate linezolid. So in this situation, I would say that bedaquiline extension throughout the course of the treatment would be a wise thing to do because he's doing well, he's responding well. And many times we see these kind of patients who do well, who've got a limited disease, but when after the IP phase, when you stop bedaquiline and adequate replacement is not there, and some of the drugs we include not knowing their DST, after a few months or few weeks, this patient relapse and they come back with worsening of the disease. Next slide. Next. So one of the important replacement principle is to modify the longer regimen. You must review the resistance pattern. Here we are badly missing having a complete DST available for all the drugs, but unfortunately through the national program, we could not get the complete DST done, and patient was not affording to get it done from the private sector. And this is a very important point. I think availability of the DST pattern, even at some later stage, would help us to make important decision. Otherwise, we end up giving the patient some drug which patient may not be sensitive to and which will add to the adverse drug reaction. So resistance pattern, past history, tolerability, contraindications, and availability of the drugs. All these are important factors for things. So having taken all this into consideration, I would feel that of bedaquiline, clofa, cycloserine, trying to reintroduce linezolid and see if it always would be the right approach in this case. And delaminate and amikacin may not be introduced after initial 8 months of treatment. And during these later months, replacement sequences, pyrazinamide, ethionamide, PAS, and ethambutol. But if you think the patient is already 12 months into the treatment, and if you think about the replacement sequence, so Z is out, Ethio is out because both are resistant, PAS is not tolerating at all, and ethambutol is of questionable usefulness. So the only option I see in this case is to extend bedaquiline through the course of the treatment. Next. So give it for a complete 18 months. So I think the key messages that I would like to discuss here on this forum is that I think availability of extended DST under the program is very crucial in these cases. And we have started seeing more and more complex resistance patterns. And in real life, see, it's not only about knowing the sequence of the drug, but how the patient has past history, and that is going to be individual. That patient would have different exposures, how an individual is going to tolerate a particular drug. So that's a very important point. And in that scenario, when we don't have the complete DST available, we are kind of, we really feel stuck. Extension of bedaquiline is very crucial. And I think many times it so happened that at nodal center, patients come for follow-up, and reflexly at the end of 6 months, the bedaquiline gets stopped without having consideration of all these factors as to clinical, radiological, microbiological response, and ADRs, and having the DST available. So that kind of detailed evaluation has to be done before we take a decision of stopping bedaquiline at the end of 6 months, and field condition that becomes at times very difficult. Bedaquiline should not be stopped without all this consideration. clinical monitoring for ADR and treatment response are very important. I think many times now, as Dr. Katoch has initially shared, that the guidelines have changed very fast. So we have a lot of new weapons available, but we should also have adequate training, and the clinical training is extremely important of both medical and paramedical staff. And this will help in the process of decentralization very effectively. As Dr. Shreyas would like to share that initially, even in some of the medical colleges, routinely, the MDs, like that's what happens in Mumbai, that the students who are doing MD chest and TB do not get routine posting in the TB hospital, where they clinically see how these patients are being managed. And that when you start to practice, unless you've clinically seen the cases, you find really getting stuck at such complex situation. Dr. Shreyas had actually come to TB hospital and spent good 2 months attending all the OPDs and taking clinical training, and that has really helped him. And now I see the way he's flowered and managing the center. So that's a real process of decentralization, where along with the guideline, the clinical training should also happen. And then I think that would be a great step forward. And so with that, I
thank you, Dr. Alpha. Thank you so much. The case was excellently presented by Dr. Shreyas and discussed by Dr. Alpha. Thank you so much. With us, we have Dr. Divansar, who's a surgeon. So there's a question, what could be the role of surgery in such cases? Dr. Shreyas, could you put up the X-ray of this patient?
So this X-ray is showing on generally the disease is localized to the right upper zone. I cannot see the left side clearly. Left side looks quite okay. Was the CT scan also done, Dr. Shreyas? At any stage?
No, sir. The patient was not affording and do not have a CT scan from the corporation facility free of charge. So the patient would have had that.
I think it is an excellent case in which surgery should have been considered long time ago, even when we were making these changes in the drugs, because that would have added to the possibility of even your selection of drugs better, because you would have used lesser drugs, maybe more effective drugs after this area would have been removed, and the load of the disease would have been reduced considerably. And it's an eminently suitable case for right upper lobectomy as per this X-ray. But of course, I would like a CT scan and PFT also before taking a final decision in this matter. And I suppose if we can have a larger feeling that whatever be the ATT regimen which is being given, whether it is for drug sensitive or drug resistant cases, if the disease is localized and 4 to 6 months of supervised treatment have elapsed and yet the results are not achieved, if there is a possibility of surgical resection, that should be also considered, evaluated in detail, you put up the correct regimen. And one of the misconceptions I wish to allay, that many people think that patient has to be sputum positive, negative before the surgery can be done. No, continuation of the sputum positive state itself is an indication for surgery. They help several such cases. This was the case which should have been considered for surgery, and it can still be considered. Over. Thank you.
Yeah, thank you so much.
Can you show us the last X-ray? Last X-ray available to this patient. Lesion has much. This is 8/21.
So this is 28th of August. That is
the last X-ray.
Yes, sir.
Patient definitely has improved, and Dr. Ravinder, to my understanding, there is some lesion on left side, but I think that will not hamper the surgery, to my understanding. And I agree that he's a fit case, because when fit case we teach three things for surgery. When the patient is difficult in terms of drug resistance, and as soon as possible, I agree with you, don't wait for, although the guideline says that you wait for 6 months, but in such scenario when bacteria is it is very difficult to treat, then and lesion is localized. These are two basic principles. The surgery should have been advised, and I think he will be an ideal case for surgery. even he became culture negative, because you don't know when he will revert back.
Thank you so much, sir. That's a very good observation, a very helping observation, because surgery doesn't come as first thing in mind for us when we are in the clinics looking at the case. We have some questions on treatment and ADRs. So before I invite Dr. Singla for his comments, we'll take up these questions. Dr. Saroj, can you take this question?
Yes, ma'am. So I think many said they've asked why not continue Delaminate after 6 months. And we could have continued Delaminate till with Bedaquiline also.
So, yeah, actually Delaminate, I mean, with great difficulty, we are getting it for 6 months. So continuation is a little challenging. The availability of Delaminate is still challenging in that scenario. And here, if we say, even if we are continuing Bedaquiline, cycloserine, and clofazimine, we still have 3 good drugs which are continuing. So continuation of both the drugs is probably not required in this case, and only extension of Bedaquiline is good enough.
Yes, here I would like to add something. That as Dr. Alpha already said, that since we have 3 good drugs in the continuation phase, patient has already responded clinically, pathologically, and radiologically. So in this case, there is no need for Delaminate to be there. We have 3 good drugs which are like the Bedaquiline is bactericidal, it is sterilizing drug also. We have clofazimine, very good sterilizing drug, and cycloserine. So with this, it is not required. Another question which I want to raise through this clinic is that, as Dr. Alpha also showed, that in the guidelines it is mentioned that do not start Delaminate or injection in the continuation phase. You see, that is in general. But in a given case where Delaminate was not available earlier, but is now available, in these cases as an exception, and we are requiring the drugs for the benefit of the patient after 6 months of treatment, Delaminate can be considered. Of course, taking into consideration the opinion of the higher centers like nodal DRTB centers or maybe the difficult to treat TB clinic. So there is no absolute contraindication to Delaminate in the continuation phase in scenarios where you are not left with good drugs. So he received Delaminate from 6 months to 1 year, became culture negative, improved clinically and radiologically and pathologically. So after that, it is time to stop Delaminate because we are left with 3 drugs, that is Bedaquiline, clofazimine, and cycloserine. So it is not technically not required also. Thank you.
I would just like to have a question for all the dignitaries. Since there is a resistance to RRS mutation also, so shall we count amikacin as an effective drug, or how would we plan in this case?
Yeah, coming to the mutation, you see now the time has come, clinician, we should know the mutation pattern also. So for injectables, we have 2 kinds of mutation, broadly speaking. We have EIS mutation, we have RRS mutation. If there is RRS mutation, this indicates that all the 3 injectables, all the 3, that is kanamycin, amikacin, and Cana, Amica, and Kepremazine. Yeah, all the 3 cannot be used. On the other hand, if we have only EIS mutation, no RRS mutation, in that case, kanamycin cannot be used, but amikacin can be used and kepremazine can be used. This patient had RRS mutation, indicating that all the 3 injectables should not be used. They are likely to be drug raised. So that's how it is. Thank you.
And sir, one more point that we want to raise here is, many times this patient has moxifloxacin resistance on liquid culture DST with concentration of 1, and we do the DST for concentration of 2, it shows sensitivity. So what is this, and can this be considered, or should absolutely no?
Just as an addition to what Alpa Madam had said, so actually from the DRTB center in Kalyan sends the samples via the NTP program to infection laboratory in Thane. The infection laboratory in Thane also handles samples from Bhiwandi, Murbad, Palghar, Vasai, Vidar, Wada, Ulhasnagar, and a few sites from Mumbai, including Vaikala, Chembur, Ghatkopar, Kurla, Mira Road. So the sample drainage area of this lab is vast. And what we have observed is, if we analyze all the data of the last 3 months from this lab, there were 57 isolates with a probable low-level FQ resistance, that is the gyrase A, MUT1, MUT2, and MUT3. But 70% of them were MOXI1 resistance on the liquid culture DST. And conversely, we have also observed that among the 257 isolates which were supposed to be high-level resistance, those also the background level of resistance still remains the same. That there is 70% of them will eventually turn up resistant on the liquidity, and the remaining would turn up sensitive.
Yes, Dr. Shreyas, good that you see in the ministry they called a specific meeting sometime back, maybe around 2 years back, that what the correlation between the mutation pattern of moxifloxacin resistance and the liquid culture resistance. So as per the mutation pattern, GAIR A, MUT 1, 2 and 3A, if that is resistance, but MUT 3B, 3C, 3D are absent, in that case the high dose moxifloxacin can be used. But simultaneously, all such cases, they should be subjected to liquid culture and then decision should be taken. So what was observed in they collected the data from NITRD, from NIRT, from UP also. So what they observed was, as you are also finding, that cases who on the basis of mutation, they are likely to be sensitive to the high dose moxifloxacin, but in almost 40 to 50% of cases, the liquid culture says that they are resistant. So like in this case also, the mutation pattern suggested that high dose moxifloxacin can be used as the mutation was 2A, but it was not 3B, 3C, 3D. But later on we found that on liquid culture, the high dose moxi was resistant. So it's a request to all that whenever we take a decision to give high dose moxifloxacin based on mutation pattern, please follow up with the liquid culture DST as fast as possible, because in almost half the cases you may find that your decision of giving only the high dose moxifloxacin as a replacement drug was not good, and you may have to replace with another drug. So what people are doing based on mutation pattern, they are taking a call that they give high dose moxifloxacin and then they forget about it. No, that should not be done. Significant number of such cases will be ultimately found to be having resistance to high dose moxifloxacin, like happened in this case also. And like Dr. Shreyas also shared that is happening. So we should keep this factor in mind. Thank you.
Thank you,
Dr. Ritu wanted to say something.
Yeah, Dr. Ritu, who's a microbiologist, has been raising her hand for a long time. I'll take your question after that, Dr. Alba. Is it okay?
Yeah.
Yeah.
So Dr. Ritu wanted to add something about this MOXI concentration or no?
Yeah, actually, thanks everybody. Just wanted to add two things to what Sir has already mentioned. The EIA Sir mentioned about the level of resistance to CANA. So just wanted to add and clarify, it's just low level CANA resistance, not the high level. So high level can still be given, but obviously side effects needs to be considered. And regarding the MOXI concentration, of course, these have been actually recently only changed in 2019, the concentrations in midget. But these are based on clinical breakpoint concentrations, and that is why they are to be taken right now as it is. But later on, I mean, with more and more evidence coming, we might find that actually there may be more correlation of mutation with the treatment. But as of now, yes, as Sir has already told, the same one has to be taken because that's the clinical breakpoint concentration for midget. Thank you.
Yeah. Thank you, Dr. Ritu. Yeah, Dr. Alpa, you were adding something.
No, that's all right. I saw Ritu, Dr. Ritu wanted to add.
So there's another question. What if the all oral longer regimen fails and patient develop an active disease or continue to so that we have like already Dr. Alpa ma'am has already said that BPAL is one regimen and we can have a Salva regimen for that depending on the DST pattern. Sir, can you please highlight on this? What is the all oral?
You see, when all oral regimen fails, in true sense, even BPAL regimen patient is not eligible for. Because for eligibility for BPAL, patient should not have used bedaquiline for more than 2 weeks. But when all oral longer regimen fails, then patient has taken bedaquiline. So ideally speaking, patient is not fit for the BPAL regimen also. So there we have to go for individualized treatment regimen. In our experience with salvage regimen, we never lost hope. So what we see, we make a table, drugs taken, drugs not taken. Then we also see drugs to which the DST says it is sensitive, and drugs to which it says it is resistant, and drugs to which it is still elevated. So considering these two factors in mind, like we still have in these cases Mipinam in hand, sometimes we have Delamanine in hand, sometimes all the patient has taken linezolid, but laboratory says, a reliable laboratory says it is still sensitive. Sometimes clofazimine is available. So we have to make a permutation combination of these drugs and then try to make a regimen from these. But definitely once a longer oral regimen fails, then it becomes very difficult to make a regimen. So like in this case, we have to make all the efforts that once we are treating the drug sensitive patient, our regimen should be correct and our dosage should be correct. So very commonly, like in this case, the dosage was not correct. This could be a precursor of developing the drug resistance. So that's how we manage such cases.
Thank you, Dr. Singla. Dr. Katot sir wants to make a comment.
Thank you, Dr. Nita. I mean, beautifully presented and discussed also by each of the people, you know. And what you are suggesting, that all appears logical. You know, I just noticed two things. First, actually, I think that the culture turned negative in last October, right? And after that, it has been negative. That's what my observation.
Yes.
Yes. So for 6 months, he's already culture negative. You know, all after that also you tried is all culture negative. And so I think in this condition, what the 3 drugs or 4 drugs you are recommending, and there are no other option left. I think they appear to be the most logical. Actually, I think no interventions at this stage appear. You know, even like for surgery was discussed, and Dr. Diwan made a very nice case for that. But once something has somebody who has already responded, everything has become okay, and at that stage to do a surgery, then you know that should be a recommendation based on a prior experience of similar cases, large failures. If you know the previous cases tell that so many cases will relapse anyway, okay, then you can make a recommendation that this should be part of the surgery. Actually, the surgery should be considered, because otherwise it becomes an ethical issue. You know, that's a you're venturing into something which may have a potential benefit. But what his argument is very well taken, that even in the beginning, if you consider that, then it is a different point altogether, actually. Or is a worsening case, then is again a case this is well argued, actually. But something was responded well, and there's no indication at the moment. The only thing in the past failures experience percentages could be the point to argue that for such an intervention. And when Dr. Singla was commenting on that RRS mutations, you know, on that aminoglycosides, what he told was correct, but the point is, you know, the mutations which encode for the aminoglycosides as such are not a good predictor of the resistance, actually. So to bank on them for aminoglycosides, the same way they're tricky for the thembutol, the same way they're tricky for the pyrazinamide. I think they, as a molecular diagnosis, a criteria, they remain a very edgy game, actually. I think, as I'm concerned, because as a group lead, I mean, monitoring the same situation in the CTD for the diagnostics, we debated a huge number, a very big data actually on that. And it didn't inspire confidence to make the guidelines based on the molecular resistance detection per se, actually. So I think that should be watched as far as I'm concerned. But some more time, let's generate more data on that, and then use that as a reliable criteria to take decisions. But what Dr. Singla said, that's correct. What he said, actually, that's absolutely fine. Yes, as on now. Thank you very much. Yes.
Thank you, sir.
So may I add something respectfully? Even this X-ray, even after this culture conversion, is the patient totally asymptomatic? That's very important, because many cases of surgery we do because of post-TB sequelae. And this kind of a radiological picture, very often our experience says that they do get either positive again or start giving symptoms like hemoptysis or persistent chest symptoms. And when you get an opportunity in the thoracic surgery, if you do it reasonably early, your surgery is less complex and results are better. The more you delay it, the more it will be worse. That is my thing. That should be considered. I'm not saying the surgical decision can be taken straight away. Additional data is needed in terms of assessment of his symptoms, assessment of his cardiopulmonary status, and the CT scan to absolutely rule out lesions on the left side. Then only this will be considered.
No, Dr. Diwan, I agreed with what you said, but I totally supported the cause that, you know, it's the beginning of the treatment.
Yes,
you do, there's a great gain, or it's a worsening disease, you do, that's still very much indicated. But now in a similar case where the case for 6 months has responded, turned negative, then it should be based on a big data. If you have a data to support that so many cases will relapse, will worsen, then there is a case to recommend, actually, give an option. Yes. I agree with you. Wonderful. You know, I appreciate that. Thank you.
Thank you so much, sir. Dr. Ganesh has raised his hand.
Yes, madam. Good afternoon, madam. Am I audible?
Yes, sir, you are.
Yeah. My question is that he presently patient have completed 12 months of treatment, and he has taken 8 months of linezolid, and then we have stopped the linezolid. So after 4 months of discontinuation, can we restart the linezolid in this patient? And madam also told that we should remove the ethambutol. So if suppose we remove the ethambutol, the patient will remain with the three drugs, linezolid, clofazimine, and cycloserine. If by future, after 1 month or after 2 months, patient develop peripheral neuropathy, and we have to discontinue, if suppose linezolid, then he will remain only with the 2 drugs. So is it okay to continue with the 2 drugs if in future he develop the linezolid induced peripheral neuropathy, or should we continue with the ethambutol, linezolid, and all 4 drugs?
So can I answer this?
Sure, Dr. Alpa.
Yeah. So basically, that's what I suggested, that patient should not be only on cyclo and clopa, and we should continue bedaquiline. We should add linezolid, continue clopa and cycloserine, because ethambutol anyways we are very unsure of his efficacy at all. So in that case, suppose if the patient develops again peripheral neuropathy symptoms to linezolid, we have 3 drugs to bank upon. That's bedaquiline, clopa, and cycloserine. So bedaquiline in this case has to be continued.
Yes, may I come in? You see very clearly, as Dr. Alpa also said, the basic regimen in the continuation phase will be bedaquiline, clofazimine, cycloserine. Now, regarding the question of reintroducing linezolid with low dose or full dose, we have been using linezolid since 2005. Almost the first one in the country to use this after the Bombay group. What we see whenever the patient in the initial episode has moderate to severe neuropathy, and then you give some treatment, you stop it, and patient responds, and then you try to reintroduce, most of the time it recurs. So in that case, again, starting, stopping, so these things, and we already have at the end of 12 months, 3 good drugs, that is bedaquiline, clofazimine, and cycloserine. So if I'm there, I may not like to restart linezolid. I would like to continue with these 3 drugs, which are good enough for a continuation phase in a patient who has otherwise responded clinically, pathologically. So we may not even, as per my opinion, we may not even consider restarting linezolid because he had grade 3 toxicity in the initial episode. Thank you.
Thank you. I think we have some questions on ADR.
Yes, we have one question for ADR. What would be the risk of QTC prolongation when we are giving bedaquiline or triptyline, and the risk of developing serotonin syndrome?
So we have been using in our setup, we have been using nortriptyline up to doses of 10 milligram, 2 tablets 3 times a day. We have monitored patients for QT prolongation, and we have till date we have not found a single case of QT prolongation. Even when the patient is on 4 QT prolonging anti-TB medicines plus nortriptyline, still we have not found a single case of QT prolongation. And same with serotonin release syndrome. Till date, we have not seen a single patient.
I think still probably we need larger numbers to say, because these are potentially QT prolonging drugs. So we should be monitoring them regularly, have larger number who are on this high dose. Okay, because many times we say young females who have already prolonged QT, and then we add on these drugs, so how they're going to respond. So and very close monitoring is required. So in field condition, it's a bit challenging to start them on this high dose of nortriptyline and gabapentin, unless you are asking the patient to weekly come and get the ECG done. That is a challenge.
Regarding the QTC prolongation, we had this published also, the salvage regimen. And in the salvage regimen, we had patients on bedaquiline, delamanid, clofazimine, and high-dose moxifloxacin. All the 5 are known, all the 4 drugs are known to be cardiotoxic with increase in the QTC. But fortunately, we found only 12 patients out of 53, they had QTC prolonged, but that could be managed by temporarily stopping them. Only 1 patient required to stop the regimen as such in that scenario. So overall, what we see, maybe in India it is happening so, that the cardiac toxicity with prolonged QTC is not being observed so frequently. But like in this case, for vomiting, we also had to give ondansetron, which is partially contraindicated in patients who are on bedaquiline. Patient on bedaquiline had to be given amitriptyline, but again, patient tolerated. So some of the drugs are not absolute contraindications. We need to give them, as Dr. Alpha said, if required, we need to give them and then monitor the ECG very well so that in case there is any evidence of QTC prolongation, we are able to intervene early. So that's how the clinical management should be done. Thank you.
In fact, I would just like to add to what Dr. Singla said, that the AKT drugs are less of a problem. It's the other drug which, unknowingly gets added to patient regimen because they would go and take help from some general practitioner in the private sector. That's what is important. Patient developing vomiting and having electrolyte disturbance, that is more of an issue. That is managed well, then I think AKT drugs are very much essential. They really don't give us that much of a problem. So same like Dr. Singla said, that we also treat patients with salvage regimen, and very few of our patients we have actually had to discontinue the drug because of QT prolongation.
Right. Thank you, Dr. Alpa. So are there any more questions? No, ma'am. Since we have no more questions, can we request Dr. Singla to summarize the case for us and give us the take-home message for such cases?
So you see, I must appreciate the team of Dr. Shreyas and Dr. Alpa to pick up a very important case. Through this case, you see, we discuss about the underdosages being given, which can lead to drug resistance. We discuss about how to manage the pre-DRTB patients. We discuss about how to change the regimen once we have the drug resistance being detected. We also learned how to see once the baseline DST is not available on time, then how to manage such cases. When to give delaminate, when not to give, when to extend bedaquiline. So all these things, then about the interpretation of the mutation patterns and then taking a clinical decision. Then in case there are ADRs to linezolid, there are ADRs to pass in the form of vomiting. Everything was discussed. So we have to keep these things in mind whenever we are faced with issues, but never give hope. Never leave hope. Always you should be practical. That ADRs, yes, they do happen in cases of drug resistant TB patients, but we need to know how to manage them. And I will also request Dr. Katoch sir, please to give some words of wisdom to us through this case. As a microbiologist, what would you like to clinicians to know about such cases? Sir, please. Dr. Katoch, please, yes.
No, Dr. Singla, I won't venture into an area which I'm not really the player, because even the microbacteriology science I left 15 years back. So that's whatever I learned, I'm talking about my common sense and the later experience of analyzing together. I think today's, I was very impressed with today's presentation actually by the initial presenter and very nice discussion, Alpha, and then everybody, Dr. Devan, yourself, Dr. Neeta, everybody gave very nice comments. See those vital questions which are coming into the mind of the people. They are very regarding the drugs which are toxic and for which you don't know how long they can be given. That experience, earlier arbitrary cutoffs were arbitrary and they were based on the trials done for that set of the patients. So what I said, when the question came of delaminate, can it be done later, or the bedaquiline, how long it can be there? So now that question, why it is coming? Because it is that guidelines don't provide that experience, or guidelines provide a cutoff based on something done somewhere. Okay. So I think the collection of such cases, Dr. Singla, and the way your clinic, the clinic is now in 26 states, even that monthly collection of what they discussed, okay, did they face the similar type of situation? What happened to their cases? I think, and then the experience of continuation. So that experience becomes the guidance for future actually. See, the fears are there, but fears are theoretical. Okay? So ultimately from the patient safety point of view, we go by the cutoffs. Okay? But they are not the sacrosanct actually. It's not God's prescription given with that is a definitive one. Okay? So I think this platform is proving to be a wonderful medium to collect that data actually. Well, did you continue it? How long you continue it? So I think even the poll which you do, survey you do, that can be done on that kind actually, in that fashion. That will not be a trial, that will not be a study, but that will be an experience actually. And then because the clinic is in partnership with the CTD, is in partnership with the National Task Force. So ultimately advice is there actually. So that
మాకు దీంట్లో పెట్టేస్తారు మేడం.
सर आप म्यूट हो गए सर.
Dr. Singla, the major goal was, but as you said, and Dr. Nita also argued, that is a, no, I don't say argued, but you highlighted that is empowerment. Surely it will be empowering, but then it will be leading to a science, a kind of science where there is evidence also. See, these cases become an evidence for others to follow. And that's how I think these 300 people were there today listening. Why they have come to listen? Because they want to listen, that kind of experience is emerging. But these cutoffs are not sacrosanct at the moment. I think that data should be captured actually. And this clinic can be a place to capture that data informally. And they'll later put it to debate actually. And I think that will be my, I think, concluding remarks. But I must say that's very, very impressed with this kind of management and seeing this strength also across the country. That means the chaos which were there for a long time, they can be brought down under control for the benefit. That's wonderful. Congratulations to all of you and best wishes.
Thank you very much, sir, for the very, very encouraging words. Thank you very much. It means a lot to us. Thank you, sir.
Thank you, sir. Now I would request Dr. Divan sir to give his closing remarks, and meanwhile we'll also float the poll. So please answer the poll. So just to inform, today we are joined by more than 18 states today, and we had about 330 spokes who joined us. So over to Dr. Divan sir.
Is the DDG Dr. Joshi joining or not?
Sir, he was to join, but I just got a message in between that he's held up with some meetings. So
actually, the zonal task force meeting is also going on. That was the, and I think I have nothing much to add. Professor Katoch has added more. I was very well aptly summarized the contents as well as his thoughts on this meeting. The scientific rigor that Dr. Katoch Sahab has promoted amongst all of us has actually led to a situation where I can safely say that within last 5 or 6 years, whatever mess that we used to talk about in the management of tuberculosis across the country has started reducing at least. That's something which I can safely say has started reducing. And after having assumed the charge of Director NIT RD, and I have been watching this clinic going on for last almost a year, the kind of interest it generates and the discussion which runs along quite rational lines. That kind of a thing that I have got 30 years experience, so I can give this drug and that drug, that is definitely diminished. We can be quite positive about it that thing is changing. It is changing, and it has changed quite significantly. It's not just the beginning of the change. It has changed quite significantly. Similarly, we attended NatCon, which Dr. Jackishan organized recently, in which the discussions were very enlightening, and people are running along the scientific lines. So, as a surgeon, I sometimes feel that our emphasis is going on too much in favor of a drug culture sensitivity and the drug to be chosen. The clinical experience and what to be given in a scenario, there is a vast data available with our TB physicians, which has been present across generations. So when we are deciding on a particular case, it should be a judicious mix of laboratory results and the clinical experience. Nevertheless, I think as all of us know that the clinic went very well. I'm grateful to my colleague Professor Singla and Dr. Nita for organizing it and taking so much pains to organize it. Thank you so much, and thanks to everybody who has joined it on behalf of NIT. Thank you.
Thank you, Dr. Divan. Thanks a lot.
Thank you so much. Thank you, Dr. Katoch sir, Dr. Jaikishan sir, then Dr. Rajendra Prasad sir. I can see Dr. Radha Muje. So all the senior faculty who have been a constant support of this clinic. Thank you so much, and thank you to all our state teams, these state TV officers, directors of STBCs, our DTOs, and all the other faculty, medical colleges. Thanks a lot for joining. Thank you. Please answer the poll before you log out.
Thank you. In fact, I find each of this clinic as a wonderful learning experience, and the way it is presented and then analyzed, we feel practically as if this is a bedside learning for us. It's a great venture, and I always recommend it to many of the people I come across who would be benefiting. Thank you, Neeta.
Thank you so much, ma'am. Thank you. Sir, you are muted.
I would request Dr. Katos to please keep on coming these difficult to treat cases, because at least microbiologically and so many things, you have a very rich experience. And I totally agree with you that based on only moleculars and this, everything has to be combined. Many times we have seen as a clinician, there is a difference of opinion between these tests. So that is also a, but that is not on the, I mean, on the evidence. Unfortunate part is this. We treat a lot of patients, but we hardly create a very little evidence. And that is why the people outside, they are taking up